that present with acute renal disease, so with acute kidney injury, and the nephritic syndrome, which of course means oliguria, hematuria and hypertension, as opposed to those that present with more chronic forms of glomerulonephritis, which I'll come on to in a moment. In terms of the acute presentations, these are often associated with an autoantibody. So for example, ANCA-positive disease associated with serum ANCA, Goodpasture's syndrome associated with anti-GBM disease, and of course lupus nephritis with anti-DNA antibodies. The more chronic forms of glomerulonephritis may present with proteinuria, with chronic kidney disease, with hypertension, and with either visible or non-visible hematuria. And the types of glomerulonephritis associated with those presentations might be focal segmental sclerosis, membranous, IgA nephropathy, and mesangiocapillary GN. I've bracketed nephrotic syndrome on this screen, the reason for that being that nephrotic patients can present acutely or chronically. So this slide illustrates that patients with a certain type of glomerulonephritis can present with any one of a number of syndromes. Certain syndromes are particularly synonymous of that type of nephritis, so let me just explain that. So, for example, membranous glomerulonephritis, perhaps the greatest number of patients would present with the nephrotic syndrome, whereas others present with lesser degrees of proteinuria or with CKD. And if we take IgA nephropathy, the predilection is that these patients present with hematuria, either visible, previously called macroscopic, or non-visible, microscopic hematuria, but also patients can present with proteinuria, with the nephrotic syndrome occasionally, even with the nephritic syndrome, and in which case a renal biopsy would show a crescentic IgA nephropathy in those patients. In terms of the basic principles of management of glomerulonephritis, firstly, if a patient has CKD with or without proteinuria as the clinical presentation, then as for other cases of CKD, the primary treatment is blood pressure control to 130/80, and particularly the use of renin-angiotensin blockade. Those patients who present with nephrotic syndrome as a general rule will be treated with steroids initially, and those patients who have an acute presentation with acute kidney injury or the nephritic syndrome, often the two go together, they will be treated with high-dose steroids, cyclophosphamide, and possibly even plasma exchange, as they are likely to have rapidly progressive glomerulonephritis. So let's consider the first question. A 17-year-old comes to clinic with ankle swelling and facial edema. Creatinine is 115 micromoles per litre, and 24-hour urinary protein excretion is 6 grams. The young man had 2 separate previous episodes of nephrotic syndrome at the age of 13 and 14 years, and on each occasion was treated with prednisolone with rapid resolution of the edema over just a few weeks. He has never previously had a kidney biopsy. On examination, he has a blood pressure of 136/78, a pulse of 80 and regular. There is peripheral pitting edema of the legs and some facial edema. So which one of the following is the most appropriate way to manage him? So this case concerns a young man with recurrent nephrotic syndrome. He's had 3 episodes of nephrotic syndrome, but we do not have a renal histological diagnosis. The correct answer is to treat him with prednisolone, as was the case for his previous 2 episodes, and then to perform renal biopsy. So let's discuss the nephrotic syndrome in general terms. There are many possible causes of adult nephrotic syndrome, and hence renal biopsy is more or less always indicated in adults. This is not the case in children, where 90% of the cases of nephrotic syndrome are due to minimal change disease. So it's a fair assumption that treating them with steroids will lead to fairly rapid resolution. One mainstay of simple supportive treatment is salt restriction and moderation of fluid intake. If the patient has a low serum albumin, such as less than 20 grams per litre, then there is a significant risk of thromboembolism, and so patients are then treated with low molecular weight heparins. To control edema, we use loop diuretics, sometimes with a thiazide diuretic, notably metolazone in combination, which enhances the diuresis. The patient should have their weight measured on a daily basis, and we do sometimes see very resistant cases of nephrotic syndrome that actually require some salt-poor albumin infused into their circulation in order to then achieve the diuresis. Considering minimal change disease itself, which was the diagnosis in this particular case, as I mentioned, 90% of childhood nephrotic syndrome is due to this condition. It still accounts for 25% of adult nephrotic syndrome. Renal impairment is rare in minimal change disease unless the patients get so hypovolemic that they develop ATN. When we perform renal biopsy, the specimen is normal by light microscopy, but abnormalities can be shown, subtle ones, with electron microscopy, and I will demonstrate that in a moment. Most cases of minimal change disease are steroid sensitive. However, they can relapse, and second-line treatments that we might use include cyclophosphamide or cyclosporin. Most cases of minimal change disease are idiopathic, but there are some rarer secondary associations such as Hodgkin's lymphoma, and non-steroidal anti-inflammatory agents can also provoke the condition. So this slide shows a normal glomerulus by light microscopy. You can see the urinary space on the outside of the glomerular tuft, and within that tuft the red areas, the dark red areas, are mesangial cells which hold the capillary loops together. Notice the thin-walled capillary loops and the degree of cellularity, the number of nuclei within this normal glomerulus. This demonstrates the electron microscopic picture of minimal change disease. On the left-hand caption, you can see the foot processes of the epithelial cell clearly, whereas on the right-hand side, which is minimal change disease, we can see that there has been foot process fusion. This is a subtle sign that we see in many cases of minimal change disease. The second question relates to a 19-year-old student who presents with visible hematuria that had begun some 2 days after an upper respiratory tract infection. He says that every time he goes to pass urine, it is reddish-brown in colour, and is extremely concerned about it. On examination, his blood pressure is 115/82, pulse is 75 and regular. He has signs of a resolving respiratory tract infection, but clinical examination is otherwise normal. On investigation, most of the parameters seen here are normal. His hemoglobin is 13.1 grams per dl. His creatinine is 102 micromoles per litre, which is perhaps slightly elevated. Urinalysis reveals 2+ hematuria, but no proteinuria, and his serum IgA is slightly elevated at 5.1 grams per litre. So which one of the following is the most appropriate initial management of this patient? So this young man is otherwise well. He has no significant proteinuria, and although the creatinine is slightly elevated at 102 micromoles per litre, the optimum management is conservative treatment of this patient. This next slide shows an immunoperoxidase stained glomerulus, and the immunoperoxidase is directed against IgA. You can see within the glomerulus, in the mesangial areas, there is dark staining concentrated there, in keeping with IgA disease. What are the associations of IgA nephropathy? Well, firstly, Hurnock-Schönlein disease is a form of IgA nephropathy. If we biopsy a patient with Henoch-Schönlein disease, by that I mean renal biopsy, then we will see IgA packed within the glomeruli. And even the skin lesions, the vasculitic skin lesions of HSP, will also contain IgA. The same is seen in dermatitis herpetiformis, where IgA is seen within the skin lesions of this particular condition. Other associations are celiac disease and cirrhosis, and there is a genetic association with a very high prevalence of IgA nephropathy actually in Japan. In terms of basic treatment of IgA nephropathy, if the patient has significant CKD and or proteinuria, then blood pressure control, as for any other case of CKD, is essential, and renin-angiotensin blockade again are the predominant antihypertensive therapies to use, and also these will minimize proteinuria. In those patients who have progressive CKD in association with IgA nephropathy, the treatment of these patients is somewhat controversial. Some studies have suggested that moderate dose steroids and perhaps other immunosuppression may be of benefit, but other studies have shown no benefit. In terms of prognosis, approximately 10% of patients with IgA nephropathy will progress to end-stage renal disease. The prognosis of patients is excellent, however, if the patient presents with hematuria alone or with only low-grade proteinuria and preserved renal function. Our third question concerns a 54-year-old woman with membranous glomerulonephritis who presents with worsening lethargy, nausea, and a rapid increase in her peripheral edema. She has previously been stable but managed with high-dose furosemide and ramipril, but she'd been in bed with a chest infection during the previous week. On examination, her blood pressure was 158/92, her pulse 82 and regular. She looks unwell with pitting edema to her mid-thigh. These are her investigations, which show a normal hemoglobin and white count, and the creatinine has increased by over 60% compared to the previous value 3 months earlier. Her albumin note is very low at 21 grams per litre. So the question is, which one of the following is most likely to explain her deterioration in renal function? The correct answer here is renal vein thrombosis. This was a lady who was unwell with a chest infection and intercurrent illness, and she already had a very low serum albumin. And as I mentioned before, patients with hypoalbuminemia are at increased risk of thromboembolism. Other possibilities that we might entertain are acute tubular necrosis in view of her intercurrent chest infection, and also progression of the underlying membranous glomerulonephropathy. How would we diagnose renal vein thrombosis? Well, most likely we would use a Doppler ultrasound scan of the renal veins rather than risk using contrast in her. The next slide shows the histological pattern of membranous glomerulonephritis. On the left-hand side we see the normal glomerulus, and on the right we can see the dense pink expansion of the membranes around the capillary loops. In this histological picture we see the silver stain showing the classical picture of spikes on the glomerular basement membrane in membranous nephropathy. The spikes are brought about by the basement membrane weaving its way around the immune complexes which are situated in the membrane. In terms of the etiology of membranous glomerulonephritis, the majority of cases are idiopathic, and within the last 12 months there has been a major discovery, and that is that many of these idiopathic cases are associated with an autoantibody which is directed at phospholipase A2 receptor. There are secondary causes of membranous GN, as there are for most types of glomerulonephritis. We have to be aware of the possibility of neoplasia, especially in the elderly population. Infections such as chronic viral infections, hepatitis B and hepatitis C, can be associated with membranous GN, and drug toxicities as we know, in rheumatoid arthritis treatments in the past, we frequently used gold and penicillamine, and these have both been associated with membranous GN. And then finally, SLE can have membranous GN as part of its histological presentation. Treatment, again, treatment of the nephrotic presenting patients is slightly controversial. Most clinicians would try to treat them with steroids. Others might try just renin-angiotensin blockade with ACE inhibitors or angiotensin receptor blockers. When the patient has CKD and proteinuria, as I've mentioned for IgA nephropathy, then blood pressure control with renin-angiotensin blockade is the fundamental therapy. In those patients with progressive CKD and membranous GN, again, we have more controversy. There have been trials that have showed some benefit with chemotherapy, namely the Ponticelli regime that you may have heard of, which was chlorambucil and steroids. However, these results have not been replicated in other studies, and the jury is still out on what the most appropriate treatment is. In terms of prognosis, 30% of patients with membranous glomerulonephritis will progress to end-stage renal disease. However, 65% of those patients presenting with nephrotic syndrome will remit, either with steroids or spontaneously. It's probably important to consider other common forms of glomerulonephritis at this point, and I'll mention FSGS and SLE nephritis. FSGS literally means focal and segmental sclerosis of the glomeruli, as evidenced in this picture, and in a more advanced form in this particular slide on the right hand side. FSGS again is often idiopathic, but there are cases associated with obesity and with reduced renal mass. So for example, patients who have a solitary kidney are at slight increased risk of developing this condition. FSGS is the nephropathy that HIV patients can develop. In terms of treatment, if FSGS patients present with nephrotic syndrome, then again we would try moderate to high dose steroids to try to control that. Those who present with CKD or proteinuria again receive blood pressure control to a target of 130/80 and the use of renin-angiotensin blockade. And for progressive CKD, again, we have no clear treatment regime. Some people would try moderate dose steroids, but others would just continue to treat them with renin-angiotensin blockade. 25% of patients with FSGS will progress to end-stage renal disease. This slide shows the histological picture of diffuse proliferative glomerulonephritis as seen in SLE. However, lupus can present with several different histological pictures, including mesangial increased cellularity, diffuse proliferative glomerulonephritis as seen here, focal proliferative GN, or membranous GN as I mentioned before. In this electron micrograph, we see the dense immune complex deposition both in the subendothelial and subepithelial positions, which are typical of the findings in SLE nephritis. In our fourth question, we are considering a 49-year-old woman presenting to the emergency department complaining of hemoptysis. She's attended her GP on 3 previous occasions over the last 6 months, complaining of recurrent nosebleeds and nasal stuffiness. Examination of the chest reveals scattered crackles and signs of consolidation, particularly on the left-hand side. On further questioning, she admits to smoking 30 cigarettes daily. Let's go on to consider her biochemistry and hematology. She is anemic with a hemoglobin of 11 grams per DL. Her creatinine is elevated at 190 micromoles per litre, and you can see that she has a positive serum anchor. The chest X-ray shows several areas of consolidation or possibly infiltration. So which one of the following is the most likely diagnosis in this case? Well, this was a lady who had recurrent sinusitis and hemoptysis and has renal impairment and a serum ANCA, and easily the best diagnosis from that list that fits is Wegener's granulomatosis. Churg-Strauss vasculitis is a possibility, but the patient did not have a history of asthma, and we're not told anything about eosinophilia, which would have been expected. In this chest x-ray, which wasn't actually the patient's, we can see widespread pulmonary infiltrates which are typical of Wegener's granulomatosis. In this slide, we see skin vasculitis around the ankle, which may be typical of ANCA-positive vasculitis. The renal biopsy might show a focal segmental proliferative lesion as shown at the bottom right-hand section of this slide, and we're aware that ANCA stands for anti-neutrophil cytoplasmic antibody, of which there are two types: C-ANCA, which is directed against proteinase 3, and P-ANCA, which is directed against myeloperoxidase. The figure demonstrates the immunofluorescence of the neutrophils stained for the autoantibody. Now, in Wegener's granulomatosis, 70% of patients have C-ANCA and 25% have a positive P-ANCA. In question 5, we consider a 34-year-old man with a history of worsening asthma presenting to the A&E department. Over the past few days, he has begun to feel generally unwell and now has severe nausea. Apparently, his GP has been increasing his anti-asthma medication, but without any benefit. On examination, his blood pressure is 167/102 and pulse 90 and regular. Auscultation of the chest reveals severe wheeze, but heart sounds are normal. Abdominal examination is also unremarkable. His results show anemia with a hemoglobin of 10.9 grams per dl, an elevated white count at 9.9 times 10 to the 9 per litre, but note that 15% of these are eosinophils. He's got severe renal impairment with a creatinine of 422 micromoles per litre. He has a positive serum ANCA. Urinalysis reveals blood and protein, and he is investigated with a renal biopsy which shows crescentic glomerulonephritis. So the question is, which one of the following is the most likely diagnosis? So the two possible answers from this list really include Wegener's granulomatosis, but by far the best answer, which really fits with the clinical picture, is Churg-Strauss syndrome, as the patient had increasing asthma and an eosinophilia coupled with the acute kidney injury. Let's consider the classification of renal vasculitides. Small vessel vasculitis is seen in Wegener's, where we see necrotizing granulomas. Churg-Strauss syndrome is associated with asthma and eosinophilia, as we've just discussed. 60% of those patients have P-ANCA, 30% are ANCA negative, actually. Microscopic polyangiitis is an ANCA positive condition which has no evidence of the above two conditions. So these patients would present with new onset acute kidney injury, with skin rash, but no signs of Wegener's granulomatosis in the upper respiratory tract, and no history of eosinophilia and asthma. Polyarteritis nodosa is a medium vessel vasculitis, which is usually ANCA negative and can be quite difficult to actually diagnose. And you'll be aware that these patients can present with non-atheromatous myocardial infarction and also gut infarction and infarction in any other organ system. And the hallmark abnormality would be seen at angiography with small microaneurysms in circulations. Other possible renal vasculitides include Henoch-Schönlein disease, Takayasu's arteritis, which of course is a large vessel vasculitis, and Kawasaki disease, which is noted in children. In terms of basic treatment for renal vasculitis, we would tend to use induction therapy with high-dose steroids and, in addition, pulsed intravenous cyclophosphamide. In brackets, I've included MMF because with certain particular patients, for example, childbearing age women, we would probably avoid the toxic effects of cyclophosphamide, which can reduce fertility, and use MMF instead. Plasma exchange will be indicated in certain clinical scenarios, especially when there is pulmonary hemorrhage, and we call that a pulmonary renal syndrome, but also in cases of severe acute kidney injury. Later on, after initiation therapy, maintenance therapy, perhaps at 3 to 6 months, would include lower dose steroids with azathioprine or some other form of immunosuppressive second-line agent. Question 6 concerns a 32-year-old man attending the clinic as an urgent referral from his GP. He's been suffering from a cough, fever, and increasing lethargy over the past few days, but most recently he has begun to suffer from hemoptysis. When he makes it to the clinic, he looks unwell with a raised respiratory rate of 31 per minute. His blood pressure is 155/82, and he has crackles at both lung bases on auscultation. His results show anemia with a hemoglobin of 10.9 grams per DL. His creatinine is elevated at 194 micromoles per litre. He is ANCA negative, has a raised ESR, and a chest x-ray shows patchy perihilar and basal infiltration. His pulmonary function tests show that the transfer factor is increased. Urinalysis reveals blood and protein, which of course would be typical of a glomerulonephritis. Which one of the following would be your management of choice for this patient? So the clinical scenario here involves a case of pulmonary renal syndrome. The patient has pulmonary hemorrhage as evidenced by the chest x-ray finding, and also the elevated transfer factor on the pulmonary function testing. The ANCA is negative, and so it is quite likely that this patient has got Goodpasture's syndrome. Therefore, the correct option would be high-dose prednisolone, cyclophosphamide as induction therapy, as I've already mentioned, and then coupled with plasma exchange. So this will be D. As you know, Goodpasture syndrome is associated with anti-glomerular basement membrane antibody, and in the top left of this slide you can see the linear IgG deposition with immunofluorescence. The bottom right part of the slide shows a crescentic glomerulonephritis. You can see the crescent of fibrosis and epithelial cell proliferation obliterating the Bowman space. So in Goodpasture syndrome, the anti-GBM antibody is directed against an antigen within type 4 collagen. It's a rare condition. We see perhaps 1 case per million population, and that compares with 20 per million for example, ANCA-positive disease. The predispositions to Goodpastures include smoking and hydrocarbon exposure. Pulmonary hemorrhage will be seen in approximately 50% of patients. In terms of the prognosis, renal recovery is unfortunately rare if the patient presents with either anuria or a creatinine of greater than 600 micromoles per litre. In terms of overall survival, approximately 80% will survive. The final question concerns a 35-year-old ex-intravenous drug user with known hepatitis C who is found to have 3+ hematuria and 4+ proteinuria on urinary dipstick testing. He has a number of non-healing skin ulcers on his lower limbs and also left-sided foot drop. A renal ultrasound scan demonstrates bilateral 11 centimetre length kidneys with normal looking cortex. When we look at his results, we can see that he's got significant renal impairment with a creatinine of 380 micromoles per litre and also significant proteinuria, 3.2 grams per 24 hours. The C4 component of complement is very low at 0.01 grams per litre, and he also has a high bilirubin of 100 micromoles per litre and AST at 900 IU per litre, in keeping with his known hepatitis C disease. Rheumatoid factor is positive, as is the ANF, and on renal biopsy, not surprisingly, we see cryoglobulin deposition and a mesangiocapillary glomerulonephritis. So in this situation, which one of the following would be the most effective therapeutic approach? The correct answer here is C, plasma exchange. This is indicated in patients with cryoglobulinemia, and of course the cryoglobulinemia is associated with the hepatitis C disease. So when we consider the value of plasma exchange in renal disease, we recognise that all cases of Goodpasture syndrome would receive plasma exchange to remove the autoantibody. Those cases of ANCA-positive vasculitis who present with pulmonary hemorrhage or with acute kidney injury. Some cases of idiopathic crescentic glomerulonephritis who have progressive acute kidney injury will also be benefited by use of plasma exchange. Cryoglobulinemia, as I've already mentioned. In cases of myeloma with hyperviscosity, there is value, and indeed in other cases of myeloma where we have cast nephropathy, currently there are trials underway assessing whether patients would be benefited by plasma exchange compared to conventional therapy. I've mentioned already that patients with thrombotic thrombocytopenic purpura and some with HUS may also benefit from plasma exchange. So this concludes the second